myocardial infarction or stroke. Cardiovascular disease is the leading cause of death worldwide, accounting for 18 million deaths per year, with deaths estimated to rise to 24 million a year by 2030. ASCVD, such as ischemic heart disease or stroke in particular, continues to be the leading cause of cardiovascular disease morbidity and mortality. Elevated LDL-C is the most readily modifiable cause of ASCVD from the population health perspective, because long-term elevated LDL-C may lead to the progression of atherosclerotic plaques. The liver regulates LDL-C levels by the expression of LDL receptors, which are able to bind with and clear LDL particles from the bloodstream. However, in many, this mechanism may not be enough to maintain ideal LDL-C levels. Consistent long-term lowering of LDL-C is needed to halt the progression of atherosclerosis and prevent cardiovascular events such as myocardial infarctions and strokes. Despite the availability of effective LDL-C lowering drugs, approximately 80% of patients with established ASCVD continue to fall short of achieving and maintaining guideline-recommended LDL-C goals, highlighting the need for new management strategies, including patient education on the importance of adherence, optimization of testing, and utilization of appropriate therapies. Elevated low-density lipoprotein cholesterol, or LDL-C, is the most readily modifiable cause of ASCVD from the population health perspective. The liver regulates LDL-C levels by the expression of LDL receptors, which can clear LDL particles from the bloodstream. The number of LDL receptors available on the liver cell surface can be reduced by the production of certain proteins. Production of these proteins can be specifically halted by targeting the messenger RNA encoding for these proteins through a natural mechanism called RNA interference. Therapies called small interfering RNAs, or siRNAs, have been developed to harness the natural pathway of RNA interference. Inclisiran is the first and only LDL-C lowering siRNA therapy. Inclisiran consists of two strands, the guide strand and the passenger strand. The passenger strand is attached to a molecule called GalNAc that allows for targeted delivery of inclisiran, specifically to liver cells. In the cytoplasm, inclisiran binds to RNA interference machinery called the RNA-induced silencing complex, or RISC. The RISC detaches the two strands of inclisiran and retains the guide strand. The guide strand directs RISC to its specific target mRNA. Once the complex has found its complementary mRNA, the mRNA gets cleaved, with one RISC complex cleaving multiple copies of its target mRNA, thereby preventing the production of the respective protein. As mentioned previously, the respective proteins reduce the number of LDL receptors available on the liver cell surface, hindering removal of LDL particles. Consequently, inclisiran increases the number of available LDL receptors, which increases hepatic LDL-C uptake and reduces LDL-C levels in the bloodstream with a long duration of effect.
Và sau đây, chương trình hội thảo khoa học xin phép được bắt đầu. Lời đầu tiên, thay mặt cho ban tổ chức, xin được gửi lời chào trân trọng và lời chúc sức khỏe tới toàn thể các quý bác sĩ đang tham dự hội thảo trực tiếp và trực tuyến ngày hôm nay. Kính thưa quý bác sĩ, buổi hội thảo khoa học với chủ đề Bệnh tim mạch do xơ vữa động mạch, Góc nhìn mới và cập nhật xu hướng điều trị được thực hiện dưới sự phối hợp của công ty trách nhiệm hữu hạn Novartis Việt Nam và Hội Tim mạch học Việt Nam. Chương trình hứa hẹn sẽ mang đến thật nhiều kiến thức bổ ích cho quý bác sĩ thông qua các phần tham luận và chia sẻ đến từ các quý báo cáo viên và chủ tọa. Và sau đây em xin trân trọng giới thiệu thành phần của chủ tọa và báo cáo viên, những người sẽ trực tiếp tham gia tham luận trong chương trình ngày hôm nay. Xin quý vị hãy dành một tràng pháo tay nồng nhiệt để chào đón sự hiện diện của giáo sư, tiến sĩ, bác sĩ Trương Quang Bình, Chủ tịch Phân hội Xơ vữa động mạch Việt Nam. Xin trân trọng giới thiệu giáo sư, tiến sĩ, bác sĩ Nguyễn Lân Việt, Phó Chủ tịch Thường trực Hội Tim mạch học Việt Nam. Xin trân trọng giới thiệu thạc sĩ, bác sĩ Vũ Hoàng Vũ, trưởng khoa tim mạch can thiệp, Bệnh viện Đại học Y Dược Thành phố Hồ Chí Minh. Xin trân trọng giới thiệu tiến sĩ, bác sĩ Phan Đình Phong, Phó Tổng thư ký Hội Tim mạch học Việt Nam. Xin trân trọng giới thiệu bác sĩ chuyên khoa 2 Trần Quang Khánh, khoa tim mạch can thiệp, Bệnh viện Trợ Rẫy. Và ngày hôm nay chúng ta sẽ chào đón sự hiện diện của tiến sĩ bác sĩ Rohit Khurana từ Trung tâm Tim mạch Harley Street, Bệnh viện Glen Eagle, Singapore. Về phía công ty trách nhiệm hữu hạn Novartis Việt Nam, xin trân trọng giới thiệu bà Karina, Giám đốc quốc gia. Xin trân trọng giới thiệu bà Vũ Văn Ái Khanh, Giám đốc y khoa. Và để bắt đầu cho chương trình ngày hôm nay, xin trân trọng giới thiệu bà Karina, đại diện cho công ty trách nhiệm hữu hạn Novartis Việt Nam sẽ lên phát biểu chào mừng chương trình. Xin trân trọng kính mời.
Hello. Good afternoon, everyone. Thank you so much for being here on a very rainy afternoon. So dear Professor Chung Quang Bing and dear Professor Yuen Latvit, and our very respectful speakers, 4 speakers today, and all of the distinguished guests here today, it is my honor to welcome you to today's symposium, Atherosclerotic Cardiovascular Disease, a novel perspective and updated treatment methods. It's actually very timely that we get together today here in the month of September, as World Heart Day is just around the corner on September 29th, on the same day as Tet Chung Tu. And we all know that CVD continues to be the leading cause of mortality in the world, with around 18.6 million deaths per year. And in Vietnam, CVD also causes roughly 170,000 deaths per year. Some of the recent news articles have highlighted that there can be up to 50% of adults in Vietnam who may have high cholesterol, but who may or may not be aware that they have this silent disease. The challenge in front of us is huge, and we must work together to lower this mounting risk for the population and also for the country. At Novartis, our mission is to discover new ways to improve and extend people's lives. We continue to invest our resources, primarily in R&D, to develop the latest treatments so that you can use them to lower the risk of your patients. As a strong signal of our commitment to the cardiovascular healthcare community, this month we launched a campaign called the Unblocked Disease Awareness Campaign to remind ourselves, our families, and our community to check our heart health and to choose our activities and diet wisely. And in the Unblocked campaign, we focus on 3 aspects. Number 1 is life unblocked. Are each one of us living life's full potential by first taking care of our heart health? Secondly, is care unblocked? Do the patients who arrive at your clinics get the right treatment at the right time? And then thirdly is Nation Unblocked. How are we increasing awareness and removing obstacles so that patients are aware, diagnosed, and treated all across Vietnam? With that mission and commitment in mind, I feel very privileged to be here today with some of the most leading experts in ASCVD. Your knowledge and insights will surely inspire us and allow us to come together to improve ASCVD prevention, treatment, and management for our patients. I would like to extend my heartfelt appreciation to all the speakers, panelists, and attendees for attending today's event. Once again, I would like to welcome all of you to the event and wishing you a very fruitful and inspiring experience with a lot of great discussion. Thank you.
Xin cảm ơn phần phát biểu chào mừng của bà Karina. Và tiếp theo chương trình xin trân trọng kính mời giáo sư tiến sĩ bác sĩ Trương Quang Bình sẽ lên phát biểu khai mạc chương trình. Xin trân trọng kính mời.
Kính thưa thầy, giáo sư tiến sĩ Nguyễn Lân Việt, Phó Chủ tịch Thường trực của Hội Tim mạch Việt Nam của chúng ta. Kính thưa 4 vị báo cáo viên và tất cả các vị đại biểu đang tham dự hội thảo chiều hôm nay trong cái phòng này. Và tất cả các anh chị bác sĩ cũng đang tham dự online hội thảo của chúng ta. Vừa rồi thì cô Karina đã nói rất rõ về cái tầm quan trọng của bệnh xơ vữa động mạch. Thống kê năm 2019 thì chúng ta thấy là tử vong do bệnh tim thiếu máu cục bộ đã đạt đến ngưỡng là 9 triệu người trong một năm rồi. Và tử vong do đột quỵ là gần 6 triệu 500 ngàn người. Như vậy thì tính cộng tử vong do bệnh lý tim mạch do xơ vữa đã đạt đến con số gần 17 triệu mỗi năm. Đây là một con số rất lớn, chứng tỏ rằng bệnh tim mạch do xơ vữa là một bệnh rất nguy hiểm và rất phổ biến. Chúng ta cần phải quan tâm điều này. Và muốn giải quyết vấn đề này thì chúng ta phải giải quyết tận gốc vào những yếu tố nguy cơ gây nên bệnh tim mạch do xơ vữa. Đó là tăng huyết áp, đó là đái tháo đường, đó là dư cân, đó là rối loạn mỡ trong máu. Và trong hôm nay thì chúng ta sẽ tập trung vào giải quyết một cái vấn đề về mỡ trong máu, rối loạn lipid máu, tăng cholesterol trong máu của chúng ta. Ai cũng biết rằng là khi mà tăng cholesterol trong máu nó gây ra những hậu quả rất nghiêm trọng, và nếu mà chúng ta tác động được, chúng ta làm giảm được cái mức LDL cholesterol trong máu thì chúng ta sẽ mang lại cái kết quả là phòng ngừa được biến cố tim mạch. Nhưng mà chúng ta làm như thế nào? Chúng ta đã làm được gì? Và trong những năm gần đây chúng ta có những chiến lược mới nào để chúng ta giải quyết vấn đề này? Chúng ta có những loại dược phẩm mới nào, những chế phẩm mới nào để có thể giải quyết được cái vấn đề rất là nguy hiểm của cộng đồng chúng ta như vậy? Đó là một câu hỏi rất lớn, và trong hôm nay chúng ta sẽ thảo luận về hai chuyện. Một là chúng ta đã có những cái chiến lược mới nào trong giải quyết giảm bớt LDL trong máu, và về vấn đề thứ hai đó là chúng ta có những chế phẩm mới nào. Cái phần đầu tiên sẽ được thạc sĩ bác sĩ Vũ Hoàng Vũ, trưởng khoa tim mạch của Bệnh viện Đại học Y Dược Thành phố Hồ Chí Minh, và bác sĩ Khánh ở Bệnh viện Chợ Rẫy sẽ giải quyết với những cái chiến lược, những cái giải pháp để mà chúng ta thực hành trong lâm sàng, có những cái phương tiện sẵn trong tay. Và trong cái phần thứ hai chúng ta sẽ có hai báo cáo viên, một là tiến sĩ Phan Đình Phong và thứ hai đó là tiến sĩ Rohit Khurana từ Singapore, sẽ nói về một cái chế phẩm mới mà chúng ta sẽ có trong sang năm 2024 để mà chúng ta có thể là điều trị được những cái tình trạng tăng cholesterol trong máu rất là nhiều. Tôi tin chắc rằng là với 4 bài báo cáo đó của 4 vị, và tôi nghĩ rằng chuyên gia tim mạch rất là có kinh nghiệm, nhiều kiến thức trong vấn đề xử lý máu, và với cái phần chia sẻ và phần điều hành của giáo sư Nguyễn Lân Việt thì chúng ta sẽ có thêm được nhiều kiến thức, có thêm được nhiều kinh nghiệm để mà chúng ta có thể xử lý tình trạng tăng cholesterol trong máu gây ra xơ vữa động mạch cho cộng đồng của chúng ta. Tôi xin chính thức khai mạc hội thảo ngày hôm nay và xin cảm ơn tất cả quý vị các đại biểu đã tham dự đầy đủ. Xin cảm ơn.
Xin cảm ơn phần phát biểu khai mạc của giáo sư tiến sĩ bác sĩ Trương Quang Bình, và sau đây xin trân trọng kính mời giáo sư tiến sĩ bác sĩ Nguyễn Lân Việt sẽ điều hành phần chuyên đề 1 của buổi hội thảo ngày hôm nay. Xin trân trọng kính mời.
Vâng, kính thưa tất cả các quý vị đại biểu và thưa toàn thể anh chị em đồng nghiệp, chúng ta sẽ bắt đầu ngay vào cái phần thứ nhất, của cái buổi hội thảo ngày hôm nay. Chúng tôi xin kính mời Thạc sĩ bác sĩ Vũ Hoàng Vũ, Bệnh viện Đại học Y Dược Thành phố Hồ Chí Minh sẽ trình bày về đề tài là kiểm soát cholesterol máu cho bệnh nhân xơ vữa động mạch, khuyến cáo điều trị và thực trạng. Xin kính mời Thạc sĩ Vũ Hoàng Vũ.
Dạ kính thưa giáo sư Nguyễn Linh Việt, kính thưa giáo sư Trương Quang Bình, các báo cáo viên và toàn thể quý đồng nghiệp đã có mặt hôm nay vào một buổi chiều thứ Bảy trời mưa. Thì cũng như cái phần trình bày trước của cô Karina cũng như là giáo sư Trương Quang Bình, chúng ta thấy cái tầm quan trọng của bệnh lý tim mạch xơ vữa rất là quan trọng, tỷ lệ tử vong rất cao trên toàn thế giới. Thì cái phần trình bày của tôi ngày hôm nay thì sẽ đề cập đến vấn đề quản lý kiểm soát cholesterol máu, mà đặc biệt là LDL cholesterol ở bệnh nhân xơ vữa, bệnh lý tim mạch xơ vữa, các khuyến cáo hiện tại và thực trạng ở một số nước như thế nào. Thì phần trình bày sẽ có 3 phần chính. Thứ nhất là chúng ta sẽ xem lại cái tầm quan trọng của kiểm soát LDL cholesterol ở trong bệnh lý tim mạch xơ vữa như thế nào. Và phần thứ hai thì chúng ta sẽ xem lại các khuyến cáo của Mỹ, của châu Âu cũng như của Việt Nam, cũng như một số trung tâm tim mạch lớn về việc chúng ta hạ LDL cholesterol trong bệnh lý xơ vữa, bệnh tim mạch xơ vữa như thế nào. Và phần thứ ba là một số cái kết quả của một số các trung tâm ở các nước cũng như là tại Việt Nam, chúng ta đã kiểm soát LDL cholesterol như thế nào trong thực hành lâm sàng. Thì phần thứ nhất chúng ta coi lược qua lại cái bệnh lý tim mạch xơ vữa nó quan trọng như thế nào. Thì chúng ta đã thấy cái phần trình bày của giáo sư Chu Quang Bình đã mở đầu cho chúng ta. Thì chúng ta thấy cái định nghĩa theo Hội Tim mạch Hoa Kỳ cũng như là theo trường môn tim mạch Hoa Kỳ, thì chúng ta thấy bệnh lý tim mạch xơ vữa lâm sàng thì chúng ta thấy là ta định nghĩa là khi chúng ta có bệnh mạch vành hoặc là chúng ta có
And those are the definition of ASCVD when patients have ACS, history of MI, unstable in China or stable in China, coronary revascularization, stroke or TIA. And those are the number from Germany, and the US. In Germany, coronary artery disease account for the biggest proportion in Germany when we talk about ASCVD, and next is CVD and PAD, around 30% to 20%. But in America, the manifestation is different. Say CAD account for 50%, PAD 42%, and CVD only 11%. So Europe or America, when we discuss about ASCVD, coronary disease account for the biggest proportion. This is a meta-analysis on more than 300,000 patients. If we reduce LDL cholesterol, that will help to improve outcome for our patient. We have 25 trials related to statin. If we reduce LDL cholesterol, then we could reduce 23% the risk of CV events. And if we use non-statin treatment, then we could reduce the risk of 25% for every 1 mmol per liter reduction of LDL cholesterol. So if we reduce LDL cholesterol by at least 1 mmol per liter, regardless of the drugs, statin or non-statin, they are always beneficial for our patient in reducing cardiovascular events. So for every 1 mmol per liter, we gain benefit. How about further reduction? Do we enjoy more benefits? According to Da Vinci trial,
Sanh ra trời đó là cái nguy cơ của bệnh nhân bị biến cố tim mạch trước khi mà chúng ta tối ưu LDL cholesterol, và cái màu xanh dương á là cái nguy cơ bệnh tim mạch, biến cố tim mạch sau khi mà chúng ta đã tối ưu hóa cái LDL cholesterol. Thì chúng ta thấy rõ
this
là
is a risk
nó luôn luôn thấp hơn
before and after treatment optimization. We could see that the green color is always lower. That means if we reduce LDL further, then patient will have higher benefit. That means less mortality, less event. So reduction is good, but lower is better. When we look at the absolute and relative reduction, what will happen? The blue colors is a reduction from 0 to 50%, and the green color is more than 50% reduction. We will have rate reduction of MACE, on-cause mortality, or major vascular event, and the best would favor the green color here. So patient with existing event, existing history, then we should aim for a reduction of at least 50% or even more. Should we reduce LDL cholesterol quickly or gradually? This is a study to show us quick reduction will have to reduce event
trên lít, và cái biểu đồ màu xám, màu tím đây là giảm trên 1.85 mmol trên lít. Thì nếu chúng ta giảm lúc đó thì hai cái nhóm này chúng ta giảm nhiều hơn và sớm trong vòng 6-8 tuần sau nhồi máu cơ tim thì sẽ giúp giảm được các biến cố tim mạch khoảng 23% cho tất cả những bệnh nhân của chúng ta. Thì nếu vậy chúng ta thấy cái việc mà hạ LDL cholesterol.
So the reduction of LDL cholesterol when we treat ASCVD, the reduction of 50% compared to baseline and achieving the target, we should aim for fast reduction within 6 to 8 months, especially after acute coronary syndrome. So how fast is it? How fast should we aim for? This is a PCSK9 trial. On the upper graph, if we aim for very low level, that would be better compared to the current standard practice, which is the yellow curve. So lower is better. Lower is better. And just within the first year, when we have the most ACS event, lower is always better. So reducing LDL cholesterol will have to reduce event for our patient with ASCVD and significant events. The benefit is independent of the mechanism of reduction, and lower is better. The benefits could be cumulative and increase over the time. So how about the current recommendation? This is ESC. We have ASCVDs or patient with high risk according to score. They stratify patient with different risk level and different target, different goals of treatment. And what should we do next? Depending on our goal, we will have different treatment. If we use statin alone and we couldn't achieve our target, then we're gonna add on ezetimibe. That will help to lower LDL cholesterol further. And if we still not reach our goal, we have to consider PCSK9. like inclisiran in order to achieve our goal. So how about America? We have similar recommendation, but their scoring system is different. For scorn, they use the 10% threshold. How about secondary prevention? According to American guideline, for very high risk ASCVD, we need high intensity or maximal statin. If we couldn't achieve this, then we need to add on PCSK9. What is the difference between Europe and America? For Europe guidelines, on ACS patients belong to very high risk criteria, but in America, they say they include recent ACS with other factors in order to say that those are very high risk, or else they only high risk, not very high risk. So it seems like European guidelines are more aggressive when they say on ACS patient belong to very high risk criteria. So the recommendation from ACC and ESC for younger patient below 75 years of age, we need to reduce LDL cholesterol of more than 50%, and for ESC, they aim for lower threshold of below 55 and 50% reduction. So European, they are more aggressive compared to American. And this is Vietnamese recommendation. We aim for a threshold of 1.4 mol per liter. That means less than 55 milligram per DL for very high risk patient. And this is recommendation from Mayo Clinic. In primary and secondary prevention, for secondary prevention, this is quite similar to ACC, and for primary prevention, they will focus on patients with high risk, especially in patients with CT calcium score of more than 300 Agatston unit. Then we need high intensity statin. Of course, first line would be high intensity statin, ezetimibe, second line to add on, and PCSK9 inhibitors could be an option when we need additional treatment. And this is the estimation of LDL cholesterol lowering. High intensity means around 50% reduction compared to baseline. We should reduce 45% LDL cholesterol level in the first 2 weeks. So maximum from statin is 50%. So how about high intensity statin? We may experience side effects. How about moderate intensity statin with ezetimibe? This is a publication from Lancet 2022. The blue color would be high intensity statin, and the red color, moderate intensity statin. After 3 years follow-up, there was no difference between two arms, but the arm with combination treatment, actually, they got better reduction of LDL cholesterol and better compliance. So in 2022, we got racing trial. And in the same year, we have ESC consensus. They say for ACS patient, we should consider upfront combination. We don't wait with sequential treatment. We should initiate combination treatment upfront. So this is another pathway, another upfront strategy with upfront combination after ACS. So those are the evidence and recommendation. What is the current practice? This is an international analysis of 42 observational studies, including Hong Kong and China. Those Asian countries, they not achieving goals is 17%, but in other countries, we have up to 70% or even 90% of patients who not achieving goals. So even though recommendation is clear, but in real world, a lot of patients couldn't achieve LDL cholesterol goal, in particular very high risk patients. This is a very famous study from Europe. Statin treated patients, most of the time they only receive moderate intensity. Only 28% patients receive high intensity monotherapy, despite the fact that they need high intensity statin. Only 9% receive the combination statin and ezetimibe like in the racing trial, and only 1% of patients receive PCSK9 inhibitor combination. According to 2016 guideline, then half of those patients could achieve their goal. So the other half didn't achieve their goal. But if we comply with 2019 recommendation, then 2/3 of patients didn't achieve their goal. This is a prospective observational registry study. The result after 2 years showing patients they have 17%, they got 17%, only 17% they intensify their treatment. Only 4% added PCSK9 inhibitor, only 3% added statin. So it is no surprise that in year number 2, very few patients, less than 20% patients could achieve the target of less than 55. 2/3 of patients have LDL cholesterol above 70 mg per dl. How about Asian patients? In this SIS2, for very high-risk patients, according to 2016 guideline, we need to aim for the level below 70, but only around 24% of patients could achieve this goal. So the majority of our patients belong to, they fall into a very big gap. This is a study including the data in Vietnam. Only 27% of our Vietnamese patients could achieve LDL cholesterol goal, very consistent with all the international trial. Võ Thị Dễ, another local Vietnamese data, only 21% of patients could achieve LDL cholesterol below 55. So what are the barriers? Those are the data from Europe with three main barriers. The first one is because of the healthcare system. Doctor and patient don't comply well because of the lack of understanding. Patient don't understand about the need to lower LDL cholesterol, and at the same time, doctors didn't really comply with guidelines, and we don't have a structured clinical pathway. And one of the important reasons why we have inadequate treatment, it is because of intolerance to statin. This is a huge number of patients. We have around 10% of patients with intolerance. There are many reasons suggesting why patient couldn't tolerate. And when patient couldn't tolerate, we need to discuss carefully with our patient. Discuss with them about the benefits, about the reason to reduce LDL cholesterol so that they could understand and comply better. And those are the number. Those are some link, some web page from America. They have American patients to understand the reason why they should comply. So with high intensity statin, the maximum reduction would be 50% of LDL cholesterol. In our hospital here, after ACS, after intervention, after coronary intervention, if we reduce LDL cholesterol by 50%, we could achieve our target. If the at baseline LDL cholesterol is around 110, so we're gonna use high intensity statin, and then like atorvastatin 80 or rosuvastatin 40. For LDL cholesterol above 110 at baseline, we will use combination upfront statin high intensity plus ezetimibe. If it is lower than 110 at baseline, then we use high intensity statin. But if patient couldn't achieve our goal, then hopefully in the future we could have all the drugs like PCSK9 inhibitor to add on. And this is a current situation in our hospital. One half of our patients use Ator, the other half use rosuvastatin. The average dose of rosu is 20 and atorvastatin 40. 99% of our patients receive high intensity statin upfront. However, when patients get discharged after 3 months, only 70% of patients continue high intensity statin. We don't have the data after 12 months.
tôi theo dõi khoảng 600 bệnh nhân thì chỉ có 47% đạt theo yêu cầu của theo cái khuyến nghị
After 3 months of follow-up, only 47% of patients achieved 2016 LDL cholesterol goal, and only a third of our patients could achieve the 2019 goal. So if we use high intensity statin alone, then only 10% of patients could achieve the goal. If we add on ezetimibe, 30% could achieve goal. However, if we add on PCSK9 inhibitor, almost 90% of patients could achieve our goals. So in conclusion, LDL cholesterol is a risk factor for primary and secondary ASCVD. Controlling LDL cholesterol helps to reduce events. We need to achieve LDL cholesterol goal ASAP. And right now, in real world, only 20 to 30% of patients could achieve our goal. The remaining 70%, 80% will need additional drugs like PCSK9 to achieve LDL cholesterol goal. Thank you so much for your listening.
Vâng, xin rất là cảm ơn phần trình bày của thạc sĩ Vũ Hoàng Vũ. Chúng ta thấy là rõ ràng là cái
Many thanks for the presentation.
LDL cholesterol mà nó cao.
We understand LDL cholesterol is dangerous when we have elevation. However, it is still challenging to control LDL cholesterol, in particular after coronary intervention. And now, specialist level 2 Trần Quang Khánh from Chợ Rẫy will share about the new understanding, the new perspective in managing LDL cholesterol, the validity and feasibility in Vietnam. Professor Dr. Trương Quang Bình, Professor Dr. Nguyễn Lân Việt, ladies and gentlemen, we have listened to Dr. Vũ Quang Vũ about the current situation of controlling LDL cholesterol in high risk and very high risk patients. We do recognize there are still certain gaps. Could we have faster control and better control to improve outcome for our patient? I would like to review the old understanding and the new understanding. The classical approach was step by step. Lower is better, but the new understanding would be lower as long as possible, and even better would be hit hard and hit fast. Will the new concept be better compared to the past? And in the future recommendation, they may have significant change. So lower is better. In the past, people recognize high LDL-C is bad. But later on, they recognize the more we reduce, the better patient enjoy the benefit, especially ASCVD patient. That's why with the latest update, LDL-C target are getting lower and lower, now even lower than 55. According to this study, there is a close relationship between LDL-C reduction and ASCVD decrease. And there is no lower limit. Actually, there is no lower limit for LDL-C, especially for high and very high risk patients. So the conclusion was lower is better. It will help to reduce the risk of ASCVD for our patient. The risk of events. Another study, they add on ezetimibe beside high-intensity statin. Improve it, show us this combination to reduce further LDL-C. Patient will have better clinical outcome, especially high and very high risk patient. Fourier with evolocumab, a PCSK9 inhibitor. Patient already received statin and they will receive add-on evolocumab. If we do that, then we could reduce further another 15% cumulative incidence. We could reduce MI, reduce angina, reduce revascularization. So we have very consistent story. Lower is better. And those are the studies so far using different drugs for treatment. Improve it. We add on ezetimibe besides statin, Fourier, PCSK9, evolocumab, an inhibitor. Or Odyssey outcome. They evaluate LDL-C and composite outcome including MI, cardiovascular death, stroke, unstable angina. So intensive treatment are always better. Better in reducing further LDL-C, and more importantly, we reduce more events. After we achieve our goal, how long we should maintain that goal? To answer that question, there are new trials to understand the reason whether we should maintain that goal for long term. The results show that the benefit of lowering LDL-C depend on both magnitude and duration of lowering LDL-C. And actually, it has been shown here, regardless of the drug we use, statin or non-statin, as long as we maintain goals of LDL cholesterol for longer, then that will be better. Regardless of the drugs we use, we could use any drugs we want to use. We reduce 12% when 12% of event when we reduce LDL cholesterol by 1 mole per liter. If we maintain that for 2 years, then we reduce events by 12%, and for 3 years we reduce by 17% of the events. So it is not only about achieving the goal, but also maintaining the goals to optimize the outcome for our patient. In patient with ASCVD, a Danish trial, after patient achieve goal, one group will continue statin and the other group they discontinue statin. They discontinue the treatment for 6 months and they compare the two arms for MI and CV death. The blue curve is patient who continue statin use. Obviously, they have less incident of events compared to statin discontinuation, and this is statistical significant difference. That's why the current goals of treatment
chúng ta mục tiêu của liệu pháp điều trị giảm lipid trong máu. Chính vì vậy cái câu hỏi đặt ra tiếp theo nữa thì chúng ta thấy ngoài cái việc là chúng ta giữ LDL-C càng thấp càng
So
tốt.
besides lower is better and lower for longer is better, what would be the change in our recommendation? Because right now our recommendation is for step-by-step approach. High intensity statin and then add on ezetimibe and then add on PCSK9 inhibitors. So when we review the new approach in hypertensive patient or heart failure patient, the lesson was early combination with different modality of mechanism will be better. That's why in LDL-C, we could have similar approach by combining multiple factors, especially patients with high or very high risk, when it is very necessary to have new approach. In patients with extremely high risk, we may even consider triple therapy upfront with PCSK9 upfront. If it is only very high risk, then we could consider doublet combination upfront. And if patient achieve the target, that means baseline LDL cholesterol reduction of more than 50% and LDL cholesterol below 55, then no further action needed. But if patient didn't achieve that, then we add on PCSK9 inhibitors. Extremely high risk, that means after ACS, patient with PAD, patient with multiple vessel disease, patient with FH, with familial hypercholesterolemia. In Swedish Heart, a study in Sweden, the percentage of patients achieving LDL-C goal, if we only use high-intensity statin, most patients couldn't achieve target. If we add on ezetimibe, we could improve this. Especially with PCSK9 inhibitor, very tiny amount of patients couldn't achieve the goal. That's why 2022 ACC expert consensus they say depending on patient risk stratification. If patient couldn't achieve the goal of 50% reduction and LDL-C below 55, then we have to evaluate their lifestyle, the current use of statin, manage the current risk factors, increase the intensity of treatment. We will be more aggressive with our treatment. Consider add-on ezetimibe with or without PCSK9 inhibitors, or bempedoic acid, or inclisiran. If patient still couldn't achieve our goal, we have to refer patient to expert. You already seen this, the difference between America and Europe. It seems like with European guidelines, it is easier with practice, and we won't miss our patient. We won't miss the high risk and very high risk patient because we know intensive treatment will carry better benefits for our patient. In patients after ACS, they have very high risk of relapse, especially in the first year. In particular, the first 3 months after MI, the cumulative of MI and stroke and CV death could be up to 10% in the first 3 months after discharge. So should we change our current recommendation? Dr. Vũ already shared with us this flow chart. With this step-by-step approach, it will take around 12 weeks to optimize the treatment and achieve LDL goals, while the first 3 months, this first 12 weeks, carry the highest risk of relapse. But right now, we still have similar approach in patients with stable ASCVD and patients after ACS, even though they have different risk profile, risk of relapse. That's why we have a consensus recently. They propose strike early, strike strong. So this approach will have to enhance the efficacy, enhance the control of LDL. We will adjust the treatment right in the acute phase and enhance the treatment after discharge with the principle of strike early and strike strong. So for right in the acute phase, they consider combination and consider adding on PCSK9 inhibitors in acute phase, especially in patients with multivessel coronary disease, polyvascular disease, recurrent events in the last 2 years, or patients with FH. We should consider PCSK9 inhibitor in acute phase insert in those patients. And then we're gonna have plan to follow up And this is a case to illustrate. This is a female, 66 years old. The diagnosis was non-STEMI, occurred in January this year. Patient has stenosis with 3 vessels. Patient have type 2 diabetes, hypertension, obesity. Patient have mixed hypercholesterolemia. And those are the testing result. But total cholesterol, glucose, HDL cholesterol. Total cholesterol was more than 300. LDL cholesterol more than 330 and triglyceride 318. So this is a very high-risk patient. And the goals for this patient is to reduce LDL-C below 55 and more than 50% reduction from baseline. So compared to baseline and our goal, we need to reduce 76%. And when we compare without treatment, the risk of relapse would be 10%. If we achieve, if we reduce 1 mmol per liter, then the risk of relapse would be 6%. Reduce 2 mmol per liter, the risk is 5%. And the same for the duration of maintaining our goal. For every mmol per liter reduction, we could reduce 2-folds of CV risk, CV events, up to 4-folds of CV events if we reduce 2 mmol per liter. So for this patient, we are aiming for 76% reduction. Then those are the recommendations. In order to achieve this, we need high-intensity statin plus PCSK9 with or without ezetimibe in order to achieve that 76% reduction. If we only use high-intensity statin plus ezetimibe, then we only reduce LDL cholesterol by 69%. So at baseline, LDL-C was 232. After high-intensity statin, we get it lower to 126, and we add on ezetimibe. However, very unlucky, in March this year, patient developed acute stroke. Patient have half-body paralysis, and on imaging, it showed a stroke. And back at that time, we checked LDL-C, the result came back up more than 100. So for such patient, according to ESC, the level for such patient is no longer 55. It should be below 40. It should be 40. So in conclusion, the message is to treat LDL-C intensively and sustainably. Lower is better, but that is not enough, especially in patients with very high risk. So the new concept is lower for longer and strike early and strike strong. We should apply those principles in our treatment. And the new treatment nowadays should help us to achieve and sustain our goals. Thank you so much for your listening.
Xin cảm ơn phần trình bày của bác sĩ Trần Quang Khánh. Rõ ràng là bây giờ cái quan điểm mới trong quản lý tăng huyết áp.
Many thanks for the presentation. Obviously, the new concept, the new understanding is lower for longer. lower is better, but not only that, lower for longer and strike early, strike strong. We have clear data. However, how about reality? We're gonna spare a few minutes to discuss in our meeting. For example, how to optimize ASCVD management optimally, the current stratification. Do we do that routinely? And about LDL cholesterol, do we advise our patient? Do we educate our patient? And do we apply the new concept? We do have new concept, but where do we apply those new concepts? And what are the barriers to apply those new concepts? We apply comments from our colleague. You could raise your hand, or you raise your hand, we send a mic to you. All right, while you are thinking, then we would like to share our thought. Everyone here understand about dyslipidemia. It is a very common risk factor, and it is associated with many events, especially ASCVD events. But in reality, in order to achieve the target, achieve our goal, like guideline mentioned, it is not simple. It is not simple to do that. Why? Because maybe both doctors and patient, we not yet don't understand the need for optimal control of LDL cholesterol. We just prescribe the drug and we don't pay attention to the real outcome, the hard outcome, and like we prescribe one tablet, one pill of Restor, one pill of Lipitor, and we think that is enough. However, we didn't stratify our patient. Without stratification, then we couldn't tell what is a target for that individual. And the third reason is maybe during admission, during hospital stay, we have very good control, but after discharge is very hard, very difficult to maintain that good control, because whether a patient could revisit, and even when they revisit, do we modify the previous treatment? Maybe we just repeat the same prescription without any up titration. And even when we up titrate the drugs, increase the dose, but we still couldn't achieve the target. Many patients are like that after statin plus ezetimibe. Some patients with cholesterol 18 mmol per liter. So that could be possible, FH. We learn a lot about PCSK9 inhibitor, but they are not available here in Vietnam. And honestly, they are very, very expensive, and we need to inject every 2 or 4 weeks. So that's why Novartis, they have a new products. We are very hopeful. We're gonna learn about that new products in the next section. There are many barriers obstructing us from achieving LDL cholesterol target. And in Vietnam, it is harder compared to other developed countries, because not every patient could afford could afford the prescription. Or maybe they could only try to comply for a very short time and then they couldn't, like, they don't have money to continue. Dr. Bình, Dr. Việt, our strategies is to control LDL cholesterol radically in Vietnam. According to Asian study and even European study, the reason for poor control belong to three groups of reasons. The first reason is the lack of testing, the lack of follow-up. Yes, we did prescribe statin, we did prescribe ezetimibe, but we don't retest, we don't monitor LDL cholesterol. That is the first reason. The second reason, we don't up titrate like 10 milligram rosuvastatin, and we keep the same, no increasing dose and no add-on treatment. So we have to unblock that barrier. That means unblocking our mindset, doctor mindset. Whenever we prescribe to treat LDL cholesterol, we have to monitor, we have to retest to see whether we achieve the target or not. If we didn't achieve target, we need to increase the treatment. Could be from low dose to higher dose or add on non-statin, such as ezetimibe. And 6 weeks or 4 weeks later, if patients still couldn't achieve target, then we increase the dose further. Maybe atorvastatin 80 milligram plus ezetimibe or rosuvastatin from 20 to 30. And of course, double check patient compliance, the lifestyle, the diet. So I think we have to focus on that, because every trial have shown us that we need to lower LDL cholesterol as low as possible, as long as possible. Any additional comments? All right, you. Good afternoon, everyone. Many thanks for the presentation. Like Dr. Vũ mentioned, the use of high-intensity statin in high-risk patients, but 70 to 80% of patients still didn't achieve target. And Dr. Khánh mentioned about a case, and I would like to ask you guys, should we use PCSK9 inhibitors plus high-intensity statin after MI with very high level of LDL cholesterol, like the case from Dr. Khánh? Should we use that combination right up front? Dr. Vũ, you want to answer that? Thanks for the question. Very practical question. I would like to make some comments about the case from Dr. Khánh. The baseline LDL cholesterol was 232 milligram per DL. So we have to consider whether this is FH, familial hypercholesterolemia. So we have to look at other factors such as familial history. We need to screen for all the family members. We need to look at that to investigate whether this is an FH case. But even with high-intensity statin plus ezetimibe, we could reduce 65% of LDL cholesterol, and at baseline it was 232. And if we are aim for 55, we couldn't achieve we couldn't achieve 55. It is impossible with those two doublets. So in this case, if we have inclisiran, then I think early combination for this patient right up front is a good option. And we could also see the recommendation, sorry, not recommendation, it is consensus from America and Europe. We could use this combination early after ACS, especially in patient with history of FH, we should use that combination upfront. Thank you. The question is very valid because some patients they have FH. Some patients they got 18, 19 mmol per liter, and we know even with maximal ezetimibe, maximal rosuvastatin, we couldn't control that. But in Vietnam, we don't have PCSK9 inhibitor. So we really hope that with this newly launched drug, and it requires one injection every 6 months, just one shot every 6 months, and great efficacy. And now we know lower is better, lower for longer is better. We understand that, but right now our available tools are very limited. I have to be honest with you, sometimes we couldn't do anything more. We couldn't do anything else. Like some patients, they have very high LDL cholesterol. We already use a very high dose of statin, but so hopefully in the near future, with the launch, with the that products was also originated from a Nobel Prize, so we are very hopeful. So with a new product could be available in Vietnam next year, but of course in Europe and in America, they did have approval. So for the next part, we're gonna focus on that compound, that new drugs in treating this lipidemia to lower LDL cholesterol. I would like to invite Dr. Phan Đình Phong from Vietnam Heart Institute, like my hospital, to present about siRNA, the current trend and prospect for ASCVD patient. First and foremost, many thanks to the chairman and the audience, and many thanks to the previous two speakers. But if this is Apple launch, my presentation is like sharing with you the official launch. I receive Novartis support for this presentation. LDL-C level is closely associated with hepatocyte recapturing of LDL-C, and for that process to happen, we need the binding of LDL-C and LDL receptor on the surface of the hepatocytes. And when we have this binding happen, endocytosis will occur, get into the hepatocytes, and after this complex is enclosed in the Clarin-coated vesicles, where acidic pH promotes the dissociation of LDL receptor and LDL-C, and LDL-C particles are then degraded, while LDL-R are recycled back to the surface. So if it is simple like that, life would be very simple. It would be very convenient, very easy for our life to control CV events. But the problems is complex because of the third factor, PCSK9. It is produced by the liver. And when we have PCSK9, it will bind with LDL receptor and LDL-C. And with this triple complex, The PCSK9 is closely bind to the LDL receptor, and that receptor couldn't come back, couldn't be recycled, couldn't come back to the surface of the cells. So PCSK9, those yellow substances will greatly reduce LDL receptor and therefore increase LDL-C in our blood. So somehow, some way, if we inhibit PCSK9, if we could reduce PCSK9 protein, then we could increase the available LDL receptor and then reduce LDL-C. Actually, in the past, we learned about PCSK9 proteins produced by our DNA. There are certain mutations, such as the gain of function mutation of PCSK9, and patients, they develop familial hypercholesterolemia, and of course, they will have much higher risk of ASCVD. But at the same time, there are certain mutations could induce the loss of function of PCSK9, and those patients, they are still healthy, and they will have very low LDL-C below the median level, and thanks to that, they will have much less CV event. Another understanding, we could use monoclonal antibodies to specifically inhibit this protein, inhibit PCSK9 protein. This treatment has been proven to reduce 50 to 60% of LDL cholesterol. So we understand that somehow if we inhibit PCSK9, we could reduce LDL cholesterol. I would like to share about the process of protein biosynthesis, the journey, the process from gene to protein production. It will go through the two-phase transcription and translation. Transcription means the transferring genetic information from DNA to mRNA. And when mRNA get to the cytoplasm, it will combine, it will slide on the ribosome to match the genetic code to create the protein. So mRNA is a center. It is a key to transfer the genetic information from DNA. It is to secure the safety for DNA, and at the same time transfer the genetic information from DNA. And in reality, only 2% of DNA are coding DNA. The other would be non-coding RNA. Non-coding RNA, they involve in regulating gene function or protein biosynthesis. Small interferon RNA, siRNA, they are short double-stranded RNA. They involve in gene silencing. So siRNA could inhibit specific protein synthesis. And that understanding has been discovered by Andrew Fine and Rag Mello, and that discovery helped them to achieve Nobel Prize for this. So this is a great discovery and new technology in order to change the biosynthesis of protein. And if we intervene this process, we could truly reduce PCSK9 protein, and thanks to that, we could reduce LDL cholesterol. Inclisiran is a siRNA. It has a very specific special task, and the specific task is to target PCSK9. For inclisiran, must be able to get into the cytoplasm. So it has been combined with, it has been conjugated with GNAC, a very special substance for better stability. And then it help, that complex will get into the hepatocytes and then get loaded to RIS. I will explain that later. This is a whole process. We have here the two strands of inclisigrams at the beginning. It is conjugated with GAIN AC that will help to increase the hepatotropic effect and with endocytosis. And after endocytosis happen, inclisiran is closely released from the endosome, and after inclisiran is slowly released from the endosome, it will get loaded into the RISC, RISC. I will explain further about RISC. RISC is abbreviated of RNA-induced silencing complex. After the loading of inclisiran into the RISC, the passenger strand would be separated. And now we only have the loaded guide strand on RISC. And that separation between passenger strand and guide strand, now the loaded inclisiran in RISC will continue to guide RISC to mRNA, the PCSK9 mRNA. This is like a single mom eager to look for a partner, and yes, they look for they do have PCSK9 mRNA, and they have a base pairing. This base pairing of guide strand of PCSK9 and PCSK9 mRNA will induce the cleavage of mRNA, and then we have the dissociation of PCSK9 mRNA and then degradation of this mRNA. Therefore, we no longer have PCSK9 protein synthesis. And this is a dosage. 300 milligrams every 6 months. It has been studied to stabilize LDL cholesterol. What is the difference between inclisiran and monoclonal antibodies? We reduce PCSK9 level, both intracellular and extracellular, and we have longer interval between doses. So every 6 months, so we have better compliance. In America, it costs around $6,000 for inclisiran, while with monoclonal antibody in America, they cost $14,000. So we have better price, reasonable cost. Best. I would like to focus on the phase 3 trials, including Orion 5, 9, 10, and 11. Orion 9 was done in FH patients. Orion 10 was done on ASCVD patients such as CAD, CVD, PAD, and Orion 11 was done on ASCVD patients or ASCVD risk equivalent. Orion 10 was done in America, and Orion 11 was done in South Africa and European countries. They compare with baseline, and the underlying disease is a maximally tolerated background statin. So that means even with optimal dose of statin, those patients still couldn't achieve their goal. And they compare with placebo, but remember, placebo arm still receive statin. In this trial, inclisiran have to reduce 55% level of LDL cholesterol, and those patients enjoy very constant reduction of LDL cholesterol. So yes, in clinical practice, we could control LDL cholesterol sustainably. Orion 10 was done in America, Orion 11 done in Europe and South Africa, which show we have consistent result, 46% reduction to 51% reduction on top of statin with or without ezetimibe. Subgroup analysis also show very consistent result regardless of female or male, regardless of BMI or different race. So those are phase 3 trials has proven the role of inclisiran in reducing LDL cholesterol of more than 50% in ASCVD patient or ASCVD risk equivalent, and very good tolerance. In the recent time, we also have pool analysis. All of those 3 trials show very consistent result of siRNA reducing at least 50% or even more of LDL cholesterol, and the efficacy was very consistent. About safety profile, even though it is a biologic drugs, but it seems like we have no additional adverse events, usually only cell-limited side injection, only cell-limited injection side reaction. How about longer term follow-up? This is Orion 3. They continue to follow up patient from Orion 1. That means a phase 2 trial. So how about long-term for many years follow-up? And the results show that in this extensive follow-up, even in real-world setting, similar to real-world setting, we still see very consistent efficacy. And in patients who already use monoclonal antibodies, how about switching to inclisiran, of course, still PCSK9 inhibitors, but now more convenient. And we still see very sustainable result. Orion 8, once again, they aim for long-term follow-up. They recruited patients from previous trials in order to answer the question, in real-world setting, what is the efficacy and safety of inclisiran, and the result from a huge amount of patients provide excellent answer. We reduce almost 50% LDL-C. And the result was very consistent, even for long term like this, because they recruited patients from the previous trials, phase 3 trials. Because this is a biologic, how about ADA, anti-drug antibodies? Do we have to worry about this? Of course, everyone will have concerns, but in Orion 8, the incidence of ADA was only 1.7% with persistent ADA response, and there was no impact on efficacy and safety. And we are still waiting for Orion 4. How about clinical outcome? We are eager to wait for that result. But right now, when they review a data set for more than 3,600 patients, they evaluate the clinical outcome versus placebo arm, and actually inclisiran has reduced significantly the combined MACE. So we will be very eager to wait for a phase 3 standardized trial. However, this current result have shown significant reduction in combined MACE. And like other people already mentioned, ESC guideline, they recommend the use of inclisiran as the next step in treating dyslipidemia, especially high and very high risk patients. Inclisiran has received great support, received approval in Europe in 2020 and FDA approval in 2021 in patients with high or very high risk. So inclisiran is a future tendency helping us to control LDL cholesterol better. The indication is for adults with primary hypercholesterolemia, genetic or non-genetic disorder, or mixed dyslipidemia. It could be combined safely with statin or with another non-statin treatment. It could be used as monotherapy in patients who couldn't tolerate statin or with statin contraindication. We hope with inclisiran here in Vietnam, this is an excellent tool for us to hit hard and hit fast, achieve early control of LDL cholesterol for ASCVD patients. Thanks for your listening.
Xin cảm ơn tiến sĩ bác sĩ Phan Đình Phong vừa cho ta những về cơ chế tác động của một cái loại thuốc.
Thanks for the sharing about the mechanism of action of inclisiran in reducing LDL cholesterol very effectively, and the approval of the drugs in Europe and America. And we will soon have this available. In Singapore, actually, they do have this. And now we're going to listen to last but not least presentation by Dr. Rohit Khurana from Singapore about comprehensive management of blood cholesterol for ASCVD patients, experience and real-world practice. Doctor, please.
Thank you very much. Thank you. Can you hear me?
Your voice is very low. Can you get close to the microphone?
I will, yes. Thank you, yeah. Is that better?
A bit better.
Okay, thank you. Well, many thanks for the introduction. My name is Dr. Rohit Khurana, and I'm speaking to you from Singapore. And first of all, my thanks to Novartis Vietnam for this very kind invitation to speak at the meeting this afternoon. I wish I could be there. I've been listening to all the talks, and I've also learned a lot from my colleagues who have spoken this afternoon. So, as you mentioned, we in Singapore have had inclisiran available for over a year in routine clinical use. And I think it's important that I can share with you, my practice and specifically a case at the end of my talk, which illustrates a very typical case where I've started to use this new generation drug. So I will start my talk, first of all, just as a follow-on from my colleague who spoke in the last lecture, and we'll discuss the importance of inclisiran in terms of helping to explore again the mechanism, which has already been discussed. But I think it's also worth mentioning again because it is such a new generation of medication that it's worth thinking about and therefore repeating. And then the future of inclisiran is really dependent on its long-term efficacy, stability for the patient, and of course, long-term safety. And my colleague also started to introduce the Orion 8 open label extension study, which was recently first announced at the ESC meeting 2 weeks ago in Amsterdam.
And I will go into a deeper dive of that data for the audience. And then I will go into sharing a case study. This is my disclaimer for today's talk. So as we've heard, it's very important to understand that LDL receptor biology is a very, very important target for influencing serum LDL cholesterol level. And we've heard that the PCSK9 is a chaperone which helps internalize the breakdown of the LDL receptor within the cytoplasm. And by inhibiting PCSK9, we can increase the LDL receptor, the surface receptor concentration, and therefore allowing further cholesterol to be internalized within the hepatocyte and therefore reducing the measured serum cholesterol level. Now, inclisiran is a new generation oligonucleotide therapeutic and the first in class of what we have available to modulate the PCSK9 protein. As you've heard as well, in the last few years, we've been routinely using a monoclonal antibody against PCSK9, whereas inclisiran uses a very clever SI, stands for small interfering RNA technology, to inhibit mRNA production and therefore the PCSK9 production. So inclisiran comprises two strands of RNA, one of which is called a guide strand, and the second strand is called the passenger strand, the importance and the function of which I'll go on to describe in the next two slides. And importantly, these two double-stranded RNA constituents are linked to what we call a GYNAC conjugate. And the GYNAC conjugate is a very important part of this compound's mechanism of action. So you've seen these slides before, but the GYNAC complex, which is linked to the double-stranded RNA, allows attachment to the ASGPR receptor, which is expressed almost exclusively on the surface of the hepatocyte. And through the interaction of the GYNAC receptor, it allows the internalization within the endosome of the RNA complex and the GYNAC complex. And the endosome then undergoes a series of pH change within inside it. And this allows two very important next stages. First of all, the GYNAC receptor is then released and is internalized and degraded. And secondly, the ASGPR receptor is then also released from the endosome and recycled to the surface of the hepatocyte. And then you have the endosome, which contains a double-stranded RNA complex. And very importantly, the RNA complex is then very slowly released into the cytoplasm from the endosome. And this is one very important point, which helps explain the long-term longevity of the RNA and the long-term efficacy of inclisiran, because the endosome shields the RNA complex from degradation, first of all, and secondly, the endosome is only very slowly releases the inclisiran into the cytoplasm. So once the inclisiran is released into the cytoplasm, then it binds to the RNA-induced silencing complex, otherwise called the RISC complex for short. And once the double-stranded RNA binds to the RISC complex, the passenger strand is released into the cytoplasm and is broken down, and functionally is not important anymore. So the importance of the passenger strand in the structure of inclisiran is to allow the configuration of the double-stranded RNA to bind onto the RISC complex. Once it's bound, it no longer has a purpose and is released. And then you're left with the guide strand attached to the RISC complex. And this guide strand, RISC complex, essentially allows the sequences on the guide strand, targets the sequence, complementary base pair sequences of the mRNA encoding the PCSK9. And the PCSK9 binds to the guide strand and ultimately undergoes cleavage, and therefore functionally becomes redundant. So you have no more mRNA which can be translated into the PCSK protein which normally would occur on the ribosome. And importantly, important to note that the loaded RISC complex has a very long half-life. And as few as 100 to 200 loaded RISC complexes are sufficient to eliminate the expression of many targeted mRNA sequences. And this is also another contributory factor to the longevity and the long half-life of injected inclisiran. So essentially, just to summarize, we have a small interfering RNA which is internalized into the hepatocyte. It results in a complex bound to the RISC complex, which allows the targeted sequence of the mRNA of interest and facilitates the degradation of that mRNA so that, and as you know, the mRNA is the template for protein synthesis. And because the mRNA is degraded, then there's no PCSK protein synthesized. And so therefore, you do not get degradation of the LDL receptor, and the LDL receptor recycles to the hepatocyte surface and allows the clearance of LDL cholesterol. And as we've heard by our colleague, the fundamental mechanism of siRNA with the RISC complex is very well understood, and the Nobel Prize for this mechanism was awarded to 2 American scientists in 2006. So it's been understood for a very long time, but it's only now, until recently, we've been able to use this effectively for therapeutics. So just to summarize, there are several very important factors which explain the durability of inclisiran. First of all, it's a fully chemically modified double RNA strand, which reduces its susceptibility to degradation within the cytoplasm to exonucleases and endonucleases. Normally, RNA is very unstable and therefore very rapidly degrades within the cell. As I mentioned, inclisiran is very slowly released from the endosomes into the cytoplasm, and the endosome is a shield for the prevention of the intracellular degradation of inclisiran. Next, the inclisiran RISC complex is also very, very mechanistically stable and therefore enhances its durability. And a single RNA RISC complex can cleave many mRNA transcripts. And so therefore, collectively, these qualities of the inclisiran allow for a very long-term effective LDL cholesterol lowering, and explains why it's only necessary to administer the drug every 6 months. So you've seen this slide, is that the efficacy of inclisiran after it's injected is first observed within about 15 to 30 days post-injection. And the durability is sustained for the full 90 days, after which we then give a second dosing, and the medication is administered every 90 days. For the first 90 days, and after the first 90 days, it is administered every 180 days, every 6 months. And you can see after 90 days, there's a slight increase there's a slight decrease in the efficacy of the LDL lowering, and hence, after the first dose, there is an injection of inclisiran given after 90 days, and subsequently, the dosing is every 180 days. And as you've heard by our former speaker, the typical LDL cholesterol reduction we usually observe from baseline is approximately 50%. So moving on to the long-term durability, and as I mentioned, the survival of a new generation treatment like inclisiran will be very much dependent on its long-term safety. And this was reported in the Orion 8 open label extension study. And this was first announced very recently on Monday, the 28th of August, at the ESC meeting in Amsterdam. So again, just to reiterate what my colleague was saying, this was a long-term extension study with up to 3 years of follow-up in patients with either established cardiovascular disease or in high-risk cardiovascular patients, and therefore given as a primary prevention treatment, or those patients with heterozygous familial hypercholesterolemia. And the patients were recruited either from the completed phase 2 Orion 3 study or one of the 3 phase 3 Orion 9, 10, or 11 phase 3 studies. And the key objective was to assess the long-term efficacy, safety, and tolerability of inclisiran of patients who entered this open label study. And the primary endpoint was the proportion of patients achieving a pre-specified LDL cholesterol goal, and this was according to the ESC 2019 criteria, and also long-term safety. So this was the format of the study, the Orion open label extension study. Essentially, the drug was administered every 180 days, every 6 months, in accordance with what we understand the pharmacokinetic quality of the drug to be. And patients were either recruited from the Orion 3 and had therefore completed 4 years in the study, or 1.5 years in the phase 3 Orion 9, 10, and 11 before being enrolled in the open label extension study. And it's important to note that in the Orion 8 study, there was no placebo arm. And so therefore, all these patients were receiving inclisiran. So the overall patient population that was enrolled were over 3,000 patients. Of those 3,000 patients, more than half were previously taking inclisiran, and nearly 50% were on a placebo before being enrolled in the open label study. And all these patients were commenced on inclisiran and completed 3 years of treatment. This is the table describing the baseline demographic of the patients enlisted in the Orion 8 population. You can see that nearly over 50% of the patients were older than 65. Nearly 2/3 of the patients were men. And as you've heard, most of these patients were recruited either from Europe, US, or South Africa, and therefore the vast majority were of Caucasian race. Over 80% had established cardiovascular disease, and just under 20% were in the high-risk primary prevention category. The baseline LDL cholesterol was just under 3 millimole per liter, or just under 120 milligrams per deciliter, and nearly 90% of patients were on background statin, and just over 15% of patients were on background ezetimibe. And what's important here is that nearly 70% of patients were on a high-intensity statin defined as rosuvastatin 20 or atorvastatin 40 milligrams. So the longest exposure of patient taking inclisiran was nearly 7 years, and over a quarter of the patients were exposed to inclisiran for nearly 4.5 years or more. So we're dealing with a significant number of patient years in total, over 12,000 patient years of inclisiran assessment. And this was the result in terms of the primary endpoint, one of which was the pre-specified lipid goal according to the ESC 2019 criteria. So for established cardiovascular disease, the pre-specified lipid criteria was to get to less than 70 milligrams per deciliter. And in those patients who were high risk and for primary prevention, the aim was to get to less than 100 milligrams per deciliter. And you can see in this overall population, between 70 and 80% achieved the pre-specified target lipid criteria of either less than 70 milligrams per deciliter or less than 100 milligrams per deciliter. And this was achieved from day one after the first dose of inclisiran. So in line with what we understand, and this is consistent with what we've seen in all the Orion data, nearly a 50% reduction in LDL cholesterol was observed, and this was noticed from as early as 90 days. So throughout the duration of the Orion 8, patients had a 50% reduction from their baseline cholesterol. And the degree of cholesterol lowering, as I mentioned, was nearly 50% from baseline. It's important to recognize that there were adverse events, and this was also one of the pre-specified primary endpoints, was the long-term safety of this drug. And you can see that there were just over 9% of patients who experienced an adverse event related to the study drug. Now, the adverse event rate, the overall and total adverse event rate nearly reached 80%. And what's very important to understand in this particular trial is that it was conducted in the COVID-19 era. And as you know, COVID-19 was particularly hard on countries in Europe, the US, and South Africa. So many of the patients, nearly 14 patients, actually suffered from COVID-19 during this study. And many of the infective and inflammatory problems that were seen as one of the defined adverse events was very consistent with either a COVID-19 related infection. One of the shortcomings of the Orion 8 was that there was no placebo, and therefore it's very hard to discern whether these inflammatory adverse events were due to COVID and related complications, or whether they were due to any other factor. In terms of serious adverse events that required more consideration because they were due to acute coronary syndromes, atrial fibrillation, pneumonia, mortality, or an acute myocardial infarction, the adverse event rate was in the region of between 1 and 2%. Because this drug acts at the level of the liver, it's important to understand that there is the side effect profile was also assessed in terms of hepatic events or new or onset worsening diabetes, which is a consideration for people who have very low LDL cholesterol levels. And what's very interesting to note is that less than 0.5%, 0.3% of patients had any hepatic dysfunction, and only 1% of patients had new onset or worsening of diabetes. It was also noted during the Orion 8 study that just over 5% of patients had a detectable inclisiran-associated anti-drug antibody response. So that's just over 5%. And it's important to note that whether a patient was ADA positive or negative, it still resulted in the same efficacy in nearly 50% reduction of LDL cholesterol from baseline. And there was no difference in the incidence of adverse events. So overall, the presence of the anti-drug antibody, although it was present in just over 5% of patients, had no impact on inclisiran's efficacy or safety profile. So in conclusion, the Orion 8 study adds an increasingly important evidence to the long-term efficacy and safety of inclisiran. Over 3,000 patients, and therefore the largest trial to date with inclisiran. Nearly 80% of patients achieved their pre-specified lipid goals, with a reduction of nearly 50% of LDL cholesterol from baseline. The presence of an inclisiran-associated anti-drug antibody was very infrequent, at just over 5%, and did not impact either the efficacy or safety of the drug. The mean cumulative exposure was just under 4 years, with a maximum of nearly 7 years of exposure to the drug. And so, in conclusion, this is consistent that the lowering effects of inclisiran are consistent with other phase 3 trials with established cardiovascular disease and high-risk primary prevention patients. And the safety profile was confirmed with a favorable and similar profile to previous reports with no new safety signals. So in summary, Orion 8 provides additional evidence to support the long-term safety and tolerability of inclisiran in patients with high cardiovascular risk and elevated LDL cholesterol. So I'd like to just in the closing few slides, just share with you the most updated 2023 ESC guidelines for the management of acute coronary syndrome. Now, this is a busy slide, and I'd like you to focus on the lower right-hand side of this slide. And the ACS guidelines are now advising or recommending that we get our LDL cholesterol to lower than 55 milligrams per deciliter. And PCSK9 inhibition has now been given a class 1 indication to be initiated when patients are on highest tolerated background statin and ezetimibe. In the guidelines, inclisiran is given a specific mention as a new generation small interfering RNA molecule. Its dosing schedule as a subcutaneous administration every 6 months is also mentioned, and the efficacy and the durability of the LDL cholesterol with inclisiran is also mentioned. So I'd like to share with you a recent case. As I mentioned, in Singapore, we have been fortunate enough to use inclisiran in routine clinical practice for over a year. And the high-risk primary prevention patients, and certainly the statin-intolerant patients, comprise an important subgroup of patients in which I, and I'm sure all of us, treat. But I think with the new ESC guidelines requiring us to get to very aggressive, less than 55 milligrams per deciliter, I thought I'd share with you a case of a recent ACS patient, which is probably very typical of all our patients. So this was a recent 73-year-old British Indian gentleman that was on vacation. He was on vacation with his wife in Bali, in Indonesia, and experienced a very classic history of three-day short onset crescendo angina. His ECG showed ischemic changes, his troponin I was elevated, and he was diagnosed on the cruise ship with a non-ST elevation MI. And he was repatriated to my hospital under my care several days later. Now, this gentleman has a background of dyslipidemia, and he was taking atorvastatin, so high-intensity statin, and he was also taking aspirin 75 milligrams once daily. No other important risk factors for ischemic heart disease. When he came to our hospital, this was the following day, early in the morning. His ECG had really normalized, very, very ordinary looking ECG, no ischemic ECG changes from the ischemic ECG whilst on the cruise ship. An echocardiogram was done while he was in the high dependency unit, and this reported his LV function to be normal. There was some anterior hypokinesia. All his valves internally were morphologically normal with preserved function. His blood tests were remarkable for a moderately elevated troponin, 537, with a mildly elevated NT-proBNP, and interestingly, he had a markedly elevated lipoprotein A. In anticipation of new drugs becoming available for lipoprotein A, I am now routinely testing my ACS patients for lipoprotein A, as I think this is certainly a recognized risk factor. And as you all may be aware, certainly in the next 12 to 24 months, we will probably be launching a new targeted drug for lipoprotein(a). So I think this risk factor as a residual marker of coronary risk will become an important treatment target. So at baseline, on 40 milligrams of atorvastatin, this gentleman's LDL cholesterol was 110 milligrams per deciliter. I did his angiogram, and as you can see, he had a very high risk ACS anatomy with a critical distal left mainstem occlusion extending into the ostial segments of the LAD and the left circumflex. And he underwent coronary intervention, which I performed, and he went Coulot procedure of a stent into the LAD and also into the left circumflex. And the final angiographic result was acceptable. And then I made some very important changes to his cholesterol lowering regimen. I changed his atorvastatin 40 to rosuvastatin 20 and also initiated ezetimibe 10 milligrams. And in my experience, now with LDL targets of more than 55 milligrams per deciliter, I know that this moderate intensity to high intensity lipid-lowering oral combination therapy will not get the majority of our patients to target. And so therefore, on the ward, I also initiated inclisiran 300 milligrams once daily as a subcutaneous one-off administration with a further dose at 90 days and then 180 days. So as in line with Singapore's experience, I'm very grateful to Novartis Vietnam for sharing with me this data from 2021 to 2022, which describes the lipid-lowering achievement in cardiac patients across Ho Chi Minh and Hanoi. And as you can see, in the ACS patients, more than 50% of patients are not achieving LDL cholesterol goals. And if we were to then increase the target guideline to less than 55 milligrams per deciliter, these numbers will be even greater. So I think, like in Singapore, Vietnam, if this data is to be used, also needs the benefit of an additional lipid-lowering agent. And I think this era of PCSK9 inhibitors is going to be a fundamental change in this treatment approach and will benefit many more patients in terms of long-term secondary risk prevention. So with that, I will thank you all for listening, and I hope this short lecture has been useful and adds on to the very important information that has previously been shared this afternoon by my colleagues. Thank you very much.
Thank you very much for a very nice presentation of Dr. Rohit Khurana. Bây giờ chúng ta sẽ chuyển sang một ít phút của cái phần thảo luận của cái.
Now let's move on to discussion. So we just enjoy the presentation by Dr. Phan Đình Phong and Dr. Rohit Khurana about the current trend and the future in treating ASCVD patients with these new drugs. Dr. Rohit Khurana also share his experience. We're gonna have a short discussion about the role of new technology, siRNA, for Vietnamese patients, and what are the candidated candidated patients should receive optimized treatment with inclisiran, and when should we initiate this treatment? Right now, we don't have this drug. However, we should think about certain candidates for these drugs.
Có lẽ tôi mời thạc sĩ Vũ Hoàng Vũ nhỉ? Anh có ý kiến trước về cái vấn đề này như thế nào?
Dr. Vũ Hoàng Vũ, your comments.
Kính thưa giáo sư Nguyễn Lân Việt, kính thưa quý đồng nghiệp.
Professor Nguyễn Lân Việt, ladies and gentlemen.
Các báo cáo viên thì chúng ta cũng thấy là cái
On the presentation,
mà chúng ta hạ cái LDL cholesterol đến cái mức mà chúng ta mục tiêu thì
we recognize that it is very difficult to achieve LDL cholesterol goals, especially high risk and very high risk. That means patients with ASCVD, we have to reduce and achieve lower than 70. Very high risk, we aim for 55 or even 40 mg per DL. So we have to pay close attention to high risk and very high risk. I think those are potential candidates to optimize the treatment. Because right now, even with high intensity statin plus ezetimibe, only 20 to 30% of patients could achieve target. Like the remaining patient, a huge proportion of patients will need inclisiran. So with inclisiran, when to start inclisiran? Should we wait until we optimize those two doublet and then we add on inclisiran? In class 1 recommendation from Europe, we could see that we wait until we optimize the two oral doublet and then add on inclisiran. Another strategy is to add on inclisiran earlier. But that recommendation is flat 2A according to ACC. So, like with baseline 235, the doublet couldn't help us to achieve the target. That's why, according to ACC, if we think even with those two oral combinations, it won't be enough, then we should consider early upfront inclisiran, but the recommendation level is only 2A. And for ACS, lower is better. And we already learned about the 3 studies showing very good reduction. We hit hard, hit fast. Thank you. Many thanks for the comments from Dr. Vũ. Dr. Phan Đình Phong, any thought from you? Ladies and gentlemen, I just want to share about the 2 different approaches. Monoclonal antibodies. But we only have that inhibition when PCSK9 has been produced and released from the hepatocytes, while with inclisiran we inhibit the production right in the cytoplasm. So, and at the same time, the price is more reasonable. In America, monoclonal antibody will cost around $14,000 USD dollars. While with implicit grant, 2 shots per year, it costs $6,000. It is easy to use, no need for cold storage. We just need abdominal subcutaneous injection. Maybe, like over the time, patient could perform cell injection, and it is safe for kidney and liver. Thanks for your comments. Any additional comments from the floor? Maybe this is a very new drug, so we are still hope for the future. So without further comments, I would like to consolidate and conclude our meeting. The meeting today with the theme of new perspective and updated trend of management, we recognize that ASCVD is one of the most important risk factors. Dyslipidemia is one of the most important risk factors for ASCVD. That's why we are seeing higher and higher prevalence of ASCVD. LDL-C is a main culprit, and everyone agrees that LDL cholesterol as lower is better. We will have less event, but in order to do so, we need risk stratification in order to correctly, accurately stratify the risk level of our patient. And the new understanding nowadays is not only lower is better. Nowadays, the new understanding is lower for longer would be better. It sounds really easy. However, talking is easy, but doing will require plenty of effort from the whole society, doctor and patient. And we also want hit early and hit hard, strike fast in order to reduce LDL cholesterol. So as low, as early, for as long as possible. I think that is very challenging. For a very long time, classically, we use statin and then add on ezetimibe. Some patients could achieve target with that, but according to the current data, 2/3 of our patients couldn't achieve LDL cholesterol target. So this is a major challenge. The recommendation is to reduce at least 50% of baseline LDL cholesterol, and in high-risk patients, LDL cholesterol should be below 100. And for very high risk, that target is below 55 mg per dl. Most of our patients couldn't achieve those targets. Why? Because there are certain barriers. The barrier could come from both doctors and patients. Maybe both parties don't really recognize the importance and the danger of LDL cholesterol. Therefore, we didn't really reach for the target, the low target. And another reason is the lack of risk stratification. So many patients at the time of discharge, they still didn't achieve target. So it is important to advise them to revisit, continue to have monitoring of their LDL level. We also have clinical inertia. We haven't really been aggressive as needed. Maybe inadequate dose, poor diet, poor lifestyle. Therefore, we haven't achieved what we wish. some patients with combination, they still didn't achieve the target. That's why nowadays we have PCSK9 inhibitors, including monoclonal antibodies. They will help to increase LDL receptor, but the price for monoclonal antibodies is very high, and we need to use that drugs every 2 weeks. That's why today we are so happy, so delighted with the launch of inclisiran. It helps to inhibit the production of PCSK9 by degrading PCSK9 mRNA, and thanks to that, we have more LDL receptor, and that means we have more degradation of LDL cholesterol, and it is very important because we have very durable, very sustainable effect for the first 2 shots 3 months apart, but later on for maintenance, only 6 months apart, very long interval. The only problem is pretty high price here in Vietnam. However, some patients who have familial hypercholesterolemia or very high risk patient, in particular very high risk patient, these drugs will help to reduce risk of events. Then patient may consider reducing, they try to get certain amount money from certain sources. Next year, April or May, these new drugs will be available here in Vietnam, and the report show very safe profile. That would be very good news for us in the future. So those are the main content of our meeting. I want to show our appreciation to our speaker, especially our Singaporean colleagues. Very excellent presentation. And many thanks to the offline participant and online participant. Many thanks to Novartis for organizing the meeting today. Very new information. I'm sure you guys here are the first one who capture this new information. Very hot topic. Last but not least, many thanks for your kind patience until the very end, and you share very great comments. But it is a pity that we don't have we have time constraint, so we have to conclude our meeting here. Thank you and see you. Please give us a very big applause for everyone. And now Novartis representatives.
Kính thưa các quý bác sĩ, chương trình hội thảo với chủ đề bệnh tim mạch do xơ vữa động mạch, góc nhìn mới và cập nhật xu hướng điều trị.
Ladies and gentlemen, our conference has come to the end. On behalf of Novartis Vietnam, many thanks for your kind attention. Please scan the QR code on the screen for the evaluation survey. Thank you and see you. Goodbye, Dr. Rohit Rukana.
Với các bác sĩ đang tham dự offline tại chương
for the enjoyment of participating.
Và với các quý bác sĩ đang tham dự